name is Valerie DeVilliers, and I'm going to present to y'all today my comprehensive case study. Patient's initials are MD. She's a 22-year-old white female, English speaking. Her chief complaint today is, in quotations, I have been having horrible nightmares and I feel numb. I recently was in a bad car wreck and I should have died, but only walked away with a few scratches and bruises. I keep having flashbacks of the car wreck and it feels so real that I get anxious. My heart starts to race and sometimes I even start crying. History of present illness. Patient reports symptoms started about 2 weeks ago. Patient reports she was in a major car wreck about 3 weeks ago, and since the wreck, she has not felt the same. She reports that even though her car was totaled and flipped over 3 times, she was able to walk away from the crash with just minor injuries. Since the accident, she reports increased trouble sleeping, nightmares every night, and flashbacks during the day about the wreck. She feels anxious all the time and is scared to get in a vehicle, and is not driven since the wreck due to her having a panic attack. Even thinking about getting in the car and makes her feel anxious and her heart starts racing, and she states, I feel short of breath, like an elephant is on my chest when this happens. She reports it has been hard for her to focus on her studies with school and that she does not feel like hanging out with her friends anymore and has been avoiding social events. She also reports that she has been locked up in her room often. Over the past 2 weeks, she reports trouble falling and staying asleep and waking up from nightmares 2 to 3 times a night, reports decreased interest in social activities, and has not done anything fun since the car wreck. She reports crying a lot, decreased energy, reports decreased concentration, and having a hard time focusing on studies and work. She states, I feel like I'm in a daze and just going through the motions. She reports decreased appetite, but no significant weight loss or gain. She denies suicidal ideations and homicidal ideations. She denies auditory hallucinations and visual hallucinations. She reports feeling detached from her body at times. As far as safety, she states, I only feel safe at home in my room. I do not want to leave in a vehicle or drive since the accident. General review of symptoms. She denies chills, fever, or weight changes. She reports increased fatigue since wreck. She denies hearing loss, denies sinus pressure, denies visual changes, denies cough, shortness of breath, or wheezing. She denies chest pain at this time, no edema. She reports palpitations, but no palpitations noted on auscultation. She denies painful urination, polyuria, or increased frequency. She denies dizziness, numbness, or weakness. She denies cold or heat intolerance or polydipsia or polyphagia. She denies easy bruising or bleeding. She denies any skin lesions. She's awake, alert, oriented ×3. Perla is intact. Reports increased anxiety, flashbacks, and nightmares about the wreck. Patient is very shaky during the appointment and tapping her fingers on her legs. She reports difficulty concentrating and pauses a lot when speaking. She's afraid to leave her home or ride in a vehicle. Past psych history, no prior psych history. She reports, as far as past medical history, iron deficiency anemia. Past surgical histories, no surgeries. Allergies, no known drug allergies. Current medications include ferrous sulfate, 325 milligrams once daily, and a women's daily multivitamin. She takes the sulfate for iron deficiency anemia. Family medical history, her mother 44, hypertension, father 46, hyperlipidemia, paternal grandmother 88, hypertension and type 2 diabetes, paternal grandfather 89, he is deceased and had heart failure, maternal grandmother 78, dementia, maternal grandfather 79, heart failure and hypertension, sister 18, no medical history, no family history of mental illness. Social history. Patient is single with no children, lives alone in an apartment complex, has a bachelor's degree in nursing, no legal problems. She reports a great relationship with family and friends. She reports she was raised by her parents who are still married and they were financially stable growing up. Reports her childhood was good and she was involved in school clubs and sports. She denies any history of trauma or abuse in her childhood. She denies any alcohol or drug use now or ever. She denies any history of tobacco use now or ever. She does report that she drinks 1 to 2 cups of coffee per day and 1 soda or tea occasionally. Patient's vital signs on physical examination: blood pressure 124/68, respirations 18, heart rate 99, O2 98% on room air, temp 97.8, height 64 inches, weight 132. Her BMI is normal. General appearance: she has no acute distress. She's alert and oriented times 3. Head is normal cephalic, atraumatic. Patient has a flat affect and not smiling. Patient is wearing her pajamas and lounge clothes to her appointment and hair is not brushed. Pupils are equal and reactive to light and accommodation with the extraocular muscles intact bilaterally. Tympanic membranes are normal bilaterally. Nose and throat nares are patent. Oropharynx is clear without exudate or erythema. Neck, trachea is midline. No cervical lymphadenopathy noted. Lungs clear to auscultation bilaterally without wheezes, rales, or rhonchi. Breath sounds are equal bilaterally. Heart rate is regular and rhythm without murmurs. Rubs or gallops. Heart rate is slightly high for age. Abdomen, positive bowel sounds times 4. Soft, non-distended. No CVA tenderness. Illicit extremities reveal no clubbing, cyanosis, or edema. Dorsalis pedis pulses are +2 bilaterally. Cranial nerves are intact. Deep tendon reflexes are equal bilaterally, and motor strength is 5 out of 5 bilaterally and equal. System stressors using the Newman system model from Newman and Fawcett 2011. The primary stressors for the patient is that she had a recent car wreck, which is an extrapersonal stressor. An external environment stressor caused a psychological stressor to the patient. The stressor has broken the patient's normal line of defense and is causing psychological harm as evidenced by anxiety, nightmares related to the accident, poor sleep, sadness, and fear of driving or riding a vehicle. Patient also reports flashbacks during the day. These symptoms and this stressor is activating the patient's line of resistance. The other stressor is fear of riding or driving in a vehicle. This is an intrapersonal stressor for the patient because it causes emotional stress for the patient just by thinking about it. This is a psychological and social cultural stressor because it affects the patient's mental well-being and ability to go out in society and have relationship with friends and family, and the patient's ability to work. Third, her anxiety is an intrapersonal stressor because it is directly affecting her as an individual. All of these stressors are breaking the patient's normal line of defense, causing physical symptoms such as palpitation, shakiness, anxiety, nightmare, stress, and sadness in the patient. Diagnosis for the patient. From DSM-5, I came up with the diagnosis of acute distress disorder due to the symptoms being related to a traumatic event within the last month. Differential diagnoses include panic disorder, but according to the DSM-5, panic attacks are common in acute stress disorder. However, for it to be this diagnosis alone, the panic would have to be unexpected and not related to a traumatic event. The next diagnosis I put was traumatic brain injury. When a brain injury occurs in the context of a traumatic event, symptoms of acute distress disorder could appear. But this has been ruled out by a normal CT scan of the brain. Post-traumatic stress disorder. Patient does not meet the criteria for PTSD at this time due to the time frame of the event. If the symptoms persist past 1 month, the patient may then be diagnosed with post-traumatic stress disorder. Treatment plan. Pharmacological intervention for the patient will include medication management. I will start the patient with the SSRI. I would prescribe a citalopram, 10 milligrams once daily. I also would prescribe propranolol, 10 milligrams BID PRN for anxiety and panic. This will also help lower her heart rate because it is a beta blocker. Labs and other diagnostic studies. Patient had a CT of the brain post-accident which showed no acute abnormalities and no traumatic brain injury. Patient also had a recent CBC and CMP, which was normal, so her iron deficiency anemia, her medicine is working for that. There's no other lab recommendations at this time. Education for the patient, which is secondary prevention. I would educate the patient. It can take 1 to 2 weeks for the drug to get in the system well and up to 4 to 6 weeks to see effectiveness. The medication should improve your mood, increase energy, and decrease fatigue. I would notify the patient that this drug needs to be taken daily and try not to skip or miss doses. I would educate the patient on common side effects, which include sexual dysfunction, such as decreased sexual desire. GI upset is common, decreased appetite, nausea, diarrhea, constipation, dry mouth, and sometimes this medication can cause sedation, agitation, tremors, headaches, or dizziness. I would want to be notified of any increased bruising or rare bleeding. Please notify me immediately if you feel any increased suicidal ideations or behavior. And please never stop taking the drug immediately without proper taper dosing to avoid withdrawal effects of this drug. Non-pharmacological interventions for the patient, which is also secondary prevention, I would refer to counseling for individual therapy. Therapy I would want for the patient would be trauma-focused cognitive behavioral therapy, which can be very effective in helping patients with acute stress disorder. It'll also be good to talk to a therapist about what you're going through currently and how to work through your feelings. Exposure therapy is often a good therapy for someone with acute distress disorder. Health promotion and prevention strategies. After the patient has this acute phase has gotten better, this would be more of a tertiary prevention for the patient. Try to exercise regularly. Try to eat healthier and cut back on sugar, processed foods, soft drinks, and caffeine. Try writing down 3 things you're grateful for every day and post it on your fridge or somewhere where you can read it every morning. And try to stay social with your friends and family. Try to get regular sleep and get a good 8 hours of sleep. And please try to avoid alcohol intake due to its ability to make symptoms of depression or anxiety worse. The interventions the nurse practitioner is implementing in this plan are secondary and tertiary interventions. Hamrick's role competencies from Tracy et al. 2023. Direct clinical practice, the central competency of the APRN. In this scenario, the APRN is using a holistic treatment plan as well as evidence-based practice and clinical expertise. These are all roles of direct clinical practice. Next would be evidence-based practice. The treatment plan and decision-making process to come up with the patient's diagnosis was made by using evidence-based practice process described in Hamrick and Hansen's role competencies. And collaboration. The APRN in this scenario is collaborating with other healthcare professionals by consulting the expertise of a counselor to help the patient get therapy treatment. The APRN may also seek expert opinion from the collaborating physician to come up with treatment recommendations for this patient. Nursing outcome goals. The patient will report a reduction in anxiety symptoms like panic and racing thoughts within 4 weeks of starting pharmacological and non-pharmacological interventions. If the patient consistently takes prescribed medications and engages in therapy, the anxiety levels should decrease and can be measured by self-report or standardized anxiety scales. Second nursing outcome goal would be for the patient to demonstrate improved coping skills through participation in trauma-focused therapy within 6 weeks. And the next nursing outcome goal would be the patient will maintain medication adherence and report understanding of side effects with no missed doses over the next 30 days. If the patient receives proper medication education and follow-up, then they will adhere to the prescribed regimen without discontinuation or non-compliance and will be able to recognize when to report adverse effects. Short-term follow-up for the patient would be weekly phone call check-ins for the first 4 weeks. During those check-ins, I would assess medication adherence and tolerance, monitor for side effects, especially suicidal ideation or increased anxiety, reinforce coping strategies and therapy engagement, and I would also like to do an in-clinic follow-up in 1 month. I would like to evaluate the response to the citalopram, which would include increased mood, anxiety, increased and better sleep, and increased appetite. I would like to review the PRN use of propranolol and its effectiveness. I would reassess for any new or worsening symptoms, modify medication dose if necessary. For scales, I would use the GAD-7 and the PHQ-9. I would repeat at 4 weeks and then at 8 weeks. I would use self-report and evaluation of medication adherence and refill request. And adjustment of plan. Based on symptoms improvement and deterioration, consider increasing citalopram to 20 milligrams if minimal improvement and tolerated well, and adding adjunct therapy like a sleep aid. References include Kaplan and Sadok's Synopsis of Psychiatry, the No Drug Approach to Mild Depression, the Newman Systems Model from Newman and Fawcett 2011, the Maudsley Prescribing Guidelines in Psychiatry, and Stahl's Prescriber's Guide. Thank you, everybody, for listening.